So we're going to go ahead and get started with our plenary session. And this morning's plenary is USET Tribal Health Program Support Functions of a Tribal Epidemiology Center. And Christy Duke is our presenter for this morning's session. Christy has been with USET since May of 2003. She is a senior epidemiologist and oversees USET's Tribal Epidemiology Center. In this role, she provides oversight on activities, outcomes, and data. She provides ongoing disease surveillance and investigation for a multitude of health outcomes and clinical measures, extensive data mining of cache-based resource patient management system, and manages multiple outcome-specific databases for the purposes of tracking health indicators. She utilizes record linkage software to match tribal patients to various state registries in order to identify data gaps and to elucidate the degree of racial misclassification. She has a master's in public health degree from Tulane University. So without further ado, we want to welcome Ms. Christy Duke this morning to present.
Thank you, Tevia. I appreciate that introduction. So just to reintroduce myself, because I always do. So my name is Christy Duke, and I have been with USET for 18 years now as an epidemiologist. Right now, I currently serve as the Tribal Epidemiology Center Program Manager. The first thing I'm going to do is to give you just a presentation, and then I thought I would invite some of the other epidemiologists on our staff to do a panel discussion. We have some questions that we thought might be interesting to ask and answer as epidemiologists. For those of you who don't know me, and I am seeing a lot of new names on here, I like to chat and I like to keep things kind of informal. So do not hesitate to raise your hand or to ask a question or put something in the chat. You don't need to wait to the end. If you've got a question, please feel free to ask. So with that, Tev, if you could go ahead and pull up the presentation and I'll get started. Thank you. So I'm going to present today on the functions of a tribal epicenter, but it occurred to me that there's a lot of new names, as I mentioned before. So I wanted to give some overall background, and I thought, well, maybe I just need to start at the very beginning. So go ahead, Tev. Okay, so what is epidemiology? I know if I am meeting new people and they ask what I do, a lot of times I get a, oh, I know what that is. You study skin, don't you? I do get that response. And but no, I'm not a skin doctor, or I do not study skin. Epidemiology means, it comes from the Greek epi, meaning on or upon, demos, people, and logos, study of. And that's pretty vague. That could be like anthropology or something. But really what it is, it's the study of diseases on populations. So whereas physicians and clinical medical people study diseases in individuals and treat individuals, epidemiologists and other public health practitioners, we treat and respond to the community as a whole and the population as a whole. EPIs, as we call them for short, are not medical doctors, although there are certainly doctors who are also epidemiologists. We have degrees in public health, and that's not a clinical medical specialty. It's a population-based specialty. I put the CDC definition on here. Epidemiology is the study of the distribution and determinants of health-related states or events in specified populations and the application of this study to the control of health problems. And leave it to the CDC to put that definition on there because it's pretty complicated and convoluted. So what I told my daughter when she was little, I count sick people. And that's really just the nugget of it. But we can also look at determinants of disease too. You know, epidemiologists do studies on seatbelt wearing and what is the impact of reducing death and disability because you're wearing your seatbelt. So it doesn't necessarily have to be diseases in itself, but things that affect diseases too. We also study that. So I do want to say there are kind of, well, epidemiology branches in a couple of ways, but one of the ways it branches is from research epi and applied epi. So us at the USET Tribal Epicenter, we mainly deal with applied epi. We are not researchers. We're not running clinical trials. We don't have, well, we have lots of hypotheses, but we don't conduct studies to test them by and large. So we're dealing with what's out there and making predictions based on our knowledge and the future and just what we think is going to happen based on data. So we do a lot of data mining and looking at different data sources. And was in my bio, what Tevia read, it's pretty heavy on pulling data from mainly RPMS. And that is, for those of you who don't know, the clinical computer system at most of our member tribal nations. So we do a lot of that work. And we do a lot of just advising, predicting, and assisting to develop strategies that address the reduction of disease and the promotion of health. So go ahead, Tev. So just a very brief history of epidemiology, and every epidemiologist I know just absolutely loves this story. And if they're at London, they will probably go visit this landmark. I have not been yet, but I want to. So in London, in the 1800s, I believe, I'm actually not sure of when it was. Stephen says it's his favorite story. Everybody loves the story. There was a cholera outbreak in London, and people were getting very, very sick. Obviously, it's cholera. It's a pretty severe disease, and even if it's not severe, it's certainly unpleasant. That was affecting it. And I know this map is a little small, but you can see those dots on the map. Those are cases of cholera. So John Snow, who I believe was a physician, decided that he was not going to go along with the current train of thought that disease was caused by miasmas, which is bad air. That's what they believed, that was, bad smells that was causing the disease. He mapped out the cases, and you can see the dots on there. And he saw, and it's kind of hard to see on this map, that cases were clustered around the water pumps. People, obviously then didn't have piped in water. They had to go to the pump to draw their water. So he thought that that was curious, and that it was all centered around, and the further they got from the water pump, the fewer cases there were. So, more likely that the further away from that particular pump, the more likely people were using other water sources. And he thought, well, I'm wondering if it's transmitted through the water. So he did a little experiment, a very simple experiment. And he removed the handle from the pump. And you can see on the picture at the right, the pump handle is removed. And that's kind of become it is the symbol of epidemiology, a pump with a handle removed. And lo and behold, the cases around that pump dropped dramatically. Then I believe he removed all of the pump handles, and I'm not real sure what people did for water, but I guess they got that covered somehow. The cases of cholera dropped. And so that's kind of the beginning of the study of epidemiology, is looking at populations. So whereas physicians will advise patients on how to reduce their risk and what they need to do to stay healthy, EPIs can do that too, obviously not as a physician, but really we think about, okay, how do we keep this community healthy? And we advise people on how to do that. So go ahead and go to the next slide. So what do epidemiologists do? Lots of things. So I have to say that I may have gotten a sense of inflated self-worth through this COVID pandemic. I asked my 13-year-old daughters, do people at school think it's cool that I'm an epidemiologist? Because, that's kind of cool and it's in the news right now. It's kind of like being an astronaut. It's really cool. And she informed me that no, nobody really cared. So it kind of burst my bubble, but So, what do epidemiologists do? We do lots of things. And when I'm in interviews for new epidemiologists, I always hate this question because I always think, oh gosh, where do I start? If we had one defined job, it would be really easy. So, one of the things we do is disease surveillance, and that is exactly what it sounds like. We look for cases of disease, and there are various different ways that we do that. As you know, states have reportable diseases. So certain diseases, if you get, generally it's the lab, but it can be the physicians as well, report that disease to the state. So COVID is obviously the most obvious example, but there are other infectious disease that we look at. I don't think cholera is on the list because it is so uncommon, but usually at the bottom of the list is like really weird things that you don't hardly see anymore, like cholera. So usually those things. Ebola is probably not on the list, although it might be now because we had that Ebola outbreak. But at the bottom of that list, there's usually a caveat about, very strange things that we don't see anymore. Measles is on that list. Smallpox is on that list. So there's lots of different diseases on the list that labs and physicians, they must report to the state. And the reason for that is E. coli infections. That's one that's commonly reported. So E. coli, I know you've probably heard about that in the news, which is an intestinal infection that causes severe intestinal distress, and it can be really bad. That's a reportable disease. So when those samples get sent out to the lab, and they come back positive, usually the lab reports it to the state. And the reason for that is so epidemiologists can kick into gear and they can start doing their investigation to see where did this come from. Salmonella is another one that you might hear about from time to time. It's fairly common. And is it a public health threat? And I'll just use salmonella very briefly. You can get salmonella from your pets, and you can get really sick from it. Most of the time when the epidemiologists investigate that, they say, okay, there's a case of salmonella. I talked to this person. It looks like they got it from their pet. There's a series of questions that EPIs ask to understand where that person may have gotten it. And then the person is treated and mostly nothing is done. But occasionally, if there's a lot of salmonella, it could be contaminated meat, and you'll see meat recalls. So EPIs would work with the FDA to report that there's meat recalls that need to happen. If the person's suffering from intestinal distress or salmonella or other foodborne illnesses, work in serving food, for example, the recommendation to that person was like, you probably shouldn't work until you get that cleared up. So we make recommendations. Epidemiologists and public health entities also have some powers to enforce things, quarantine, that sort of thing. And I know we've heard about that in the news. But that's just one type of disease surveillance. And right now I'm focusing on infectious disease, and things you've probably seen in your communities is mosquito monitoring. So EPIs and other public health folks actually go out. They have big CO2 machines that they put out there. They collect mosquitoes because the mosquitoes are attracted to the CO2. Then they grind them up in the blender. I know it sounds really gross. And then they test them to see if there are any mosquito-borne diseases out there that we need to worry about. A lot of the encephalitis, that's of a concern, and we're looking at mosquitoes for that. Sentinel chickens, that's kind of a fun one. And they don't do this much anymore, but it's one of my favorite surveillance systems. At firehouses, they used to keep a flock of chickens. And those chickens were called sentinel chickens. And I'm drawing a blank. Imani, if you can remind me of the what's the disease it's looking for? It's a vector-borne disease. It's in the air. It was in the news a while back. We had it. It'll come to me in a minute. So they were the chickens will die if this disease is present, and so it usually affects birds first. And so that's what they do. And once a week, the health department will come out, they'll draw the blood of the chickens and they will study it. Dead bird reports, you may have seen that, especially in the summertime. If you see a dead bird laying on the ground, please call the health department, because the health department will come and they'll test that. So all of that is disease surveillance. And what we're looking for is there a threat to the population? And all of those things are various ways that you can do that. So we also did the same thing for chronic diseases instead of infectious diseases. So things like diabetes, cancer. And we go in, we mine data sets, we look at things, hospital discharge data, and we look at RPMS as the USET Tribal Epidemiology Center. But there are also disease registries. So like every state has a cancer. Oops, you are right. Thank you. Eastern equine encephalitis. Thank you. And I know it was an encephalitis, but that's thank you, Dr. Vore. I can always depend on you. I appreciate it. So that's a severe disease that can affect you, and that's what the chickens look for. So with chronic disease, it's a little bit differently, obviously, because most chronic diseases are not an immediate threat to the community as a whole. So if you develop diabetes, you're not going to go spread that to the whole community immediately, and you need to, isolate or be in quarantine so you don't spread it around. So each state has some chronic disease registries. Most notably is a cancer registry. So when you see statistics showing the rate of cancer in different places, that's because cancer is a reportable disease, and the way they do that is a little bit different, the way they get that information than infectious disease. But a registry is kept. So, and there are very specific rules about cancer, and cancer epidemiology is a very specialized field. Whether it's a recurrence of cancer or whether it's a metastases or whether it's a brand new cancer, there are very specific rules for that. But that's so we can compare. We can compare what the rates of breast cancer are. And we can also compare outcomes because it stages the cancer. So is it stage 4 breast cancer? Is it stage 1 breast cancer? When are people getting diagnosed? Do we need to develop a early detection intervention because the people who are getting diagnosed very late? So those are all things that EPIs look at. We can also do, as I just kind of alluded to, intervention planning. So one of the things we do within USET is work with Pam Staples, who is also on this chat, who some of you know. She does chronic disease interventions with the tribal nations and helps support that. So things like diabetes camps or veggie bucks for farmers markets to promote healthy eating, promoting exercise programs or non-smoking, smoke-free environments. So those are all things that chronic disease EPIs can do. And one of the last ways that we surveil things is vital statistics, so birth and death records. I don't know if you guys remember, those of you who have had children, filling out the birth certificate so that the hospital can send it in, but they ask a lot of questions. Tennessee actually has a very robust monitoring system about pregnancy, preconception, conception, the delivery, how things went. So they can monitor birth outcomes and effects of pregnancy and childbirth on the mothers as well, because there's some maternal questions there. And death records are also a really great source of data. You obviously put down the cause of death, but one of the other things that physicians have to put down on a death certificate is contributing factors. And one of the most interesting ones that I know of is if there is a drunk driving accident, let's say it's just between two cars, and one car is the drunk driver and the other car is not under the influence, the The person in the car who is not under the influence can, it probably doesn't always happen, but it can be coded. I mean, their cause of death is that injury. And then a contributing factor is alcohol, because even though they weren't the drinker, alcohol, it was a contributing factor in the death of that person, regardless of who was doing the drinking. So we can get a lot of information from death certificates as well. We also do case investigation, and I know that I've talked about that. So just generally speaking, case investigation is when a person comes down with a particular disease, you typically contact that person and you ask them, why do basically, why do you have this disease? There are more questions because they may not know the answer to it. One of the things that are reportable diseases, probably in all states, is rabies. And that's one that we take very, very seriously. There are not a lot of human cases of rabies, but we do test bats. And we provide advice for people who have been exposed to bats, because we're really concerned. We want to keep contracting of rabies in humans down to zero, would be ideal. So rabies is something that's taken extremely seriously. My friend Shelley, who I went to public health school, is actually a public health vet. And so she is in charge of tracking down those sorts of diseases like rabies that affect both humans and animals, so that we can keep it out of the human population. And this woman adopted a puppy from a shelter, and this puppy ended up testing positive for rabies. So my friend Shelley had to go investigate that and go see who this puppy came in contact with and recommend and try to decide, okay, did the puppy chew on you? Did they mouth on you? Did you touch the puppy? And then decide whether or not to recommend rabies shots that prevent people from getting rabies. And apparently that woman had worked at a daycare center at one point in time, and she took that new puppy all over town and showed it off, and they had more kids. Preschoolers aren't the best, what doctors call, they're poor historians. So, you want to err on the side of caution at recommending that the parents get rabies shots, but she had to interview all of those kids and all of those parents to try to determine whether or not to keep them from getting rabies. So that is one thing EPIs do, and that would be an example of case investigation. Contact tracing, I'm sure you're familiar with that. So that actually was an example of contact tracing and case investigation, because you had to invest the case of rabies with the puppy, talk to the owner, figure out where the owner went, and then follow up with the contacts of the puppy. And so that would be an example of contact tracing. The other thing that we can do is study design. So as I mentioned, epidemiology can be very academic too. And so conducting different studies to test hypotheses. Clinical trials would be an example of that. And epidemiologists can design that sort of thing, monitor the data and report the data out. But there are also other kinds of studies, and I'm not going to go into the different ones, but we can design those studies and develop the methodology for how those studies should be conducted. So we also do a lot of statistics and reporting, obviously. Statistics is kind of the bread and butter. You remember the John Snow map that I just showed? That's statistics and data. So there's a whole lot of that as well. And just depending on the disease, it could be mapping. It could be, survey questions. There's a lot of different ways that you can go about that. But in addition to collecting the statistics, reporting the statistics is very important as well, because you've got to be able to communicate to the community and the decision makers exactly what's going on to the best of your knowledge and provide recommendations. So how did tribal epicenters come into being? So that's a good question. You know that I talked a lot about how labs report to the states, how states have their own disease registries and surveillance systems. So we know that under the Indian Self-Determination and Education Act in 1975, that act basically, in a nutshell, and there are probably people on this who know more about this than I do, in a nutshell, it basically said that tribes could take the money that the federal government would spend to provide different services like health services. They could take that pot of money and they could provide the services themselves, so that they're really deciding where those monies could be prioritized. And that's by and large, most of our tribal nations in our area have chosen to do that in relation to their health clinics. So under that, we started realizing that there's not, and I'm sure everybody knows this, I could give a whole talk on the lack of data in Indian country, that there's not a lot of either tribal specific or regional specific about federally recognized tribal nations. We know that there are problems with census data as it reflects the American Indian and Alaska Native population. So, but who does the federal government have a treaty and trust responsibility to? It's the federally recognized people and tribal nations. So we started realizing that there are no real public health services specifically for Indian country. All of that was funneled through the states, and there needed to be a way to collect that information and assist tribes with their public health decision making, specifically that did not go through the states because they needed to be doing it on their own. So the Indian Healthcare Improvement Act reauthorized, actually established the tribal epidemiology centers to be able to do that. And then under the permanent reauthorization of the Indian Healthcare Improvement Act, which was rolled up into the Affordable Care Act, also known as Obamacare, colloquially, that was permanently reauthorized. Prior to that, as many of you know, the Indian Healthcare Improvement Act had to be reauthorized ever so often. The permanent reauthorization made it a permanent act. So we were really happy about that, and that was really a concern when they were talking about rolling up the Affordable Care Act, because the Indian Healthcare Improvement Act was attached to that if they did a wholesale rollback, that would strip the permanent reauthorization. So that did not happen. So we were very grateful. Special diabetes program for Indians is also in the Indian Healthcare Improvement Act. So as a result, that was permanently reauthorized as well. So here's a map of the 12. There are 12 tribal epicenters. You can see the blue on the right is the largest area, and that is our area. There are not federally recognized tribal nations in each of those states. There are only 13 states that has tribal nations. So even though we have a very large area, and if there are newly federally recognized tribes, the tribal epicenter would cover them. Right now, there are only 13. But you can see, and really it's population based. You can see the other areas, and it really coincides with the IHS areas as well. So, and then there is one urban center that serves all of the urban Indian population within the United States. So there are 12, they are established, and each of the tribal epicenters are very different in the way that they function. So I'm really going to just speak to what USET does, and if there are any other tribal epicenter colleagues on that you want to speak up and, just kind of mention how y'all function, that's fine with me. So go ahead, Tev. So our overall department, we support the tribal health program support. We are basically divided into two main branches. The tribal epicenter, and that consists of these epidemiology and data improvement sub department. And we also have a tribal epidemiology center, public health infrastructure. We also have a behavioral health team and also a chronic disease team. And I just wanted to mention that, so because our epicenter is very broad and does include these departments and services, I'm talking today mainly from the epidemiology and data improvement, but I do want to give a shout out to my colleagues who work on those other teams, because they can provide you some services as well related to those different things, behavioral health and chronic disease. On the other side, on the right there, you can see clinical support, and it's really has to do with contracting about why those are separate. But we have the special diabetes program for Indians, and most of the tribal nations in our area receive funding from USET to do their SDPI. A few tribes have decided to apply for their own funding, but early on when the SDPI dollars came out, most of the tribes in our area just decided it was easier to have USET write the application and run the grant and do that sort of thing. And so we have Dietrich Taylor, who provides those services to the tribes, and so assists them. The tribes have to write kind of like a sub grant that we collect all of them and then send up, and we apply for the grant on their behalf. So most of the vast majority of the dollars that we get for SDPI is passed right through to the tribes. So we kind of provide administrative support, but Dietrich also provides clinical support. He is a nurse and a diabetes educator. And so he's able to help guide those programs. We also have a dental support center as well that's similar to the diabetes program that we have, and we provide guidance and support to dental clinics and provide information regarding dental public health interventions. So as far as our TEC services and epidemiology, we can do a lot of these things, and I want to just make the offer. If you need assistance with any of these things, you can reach out to us and we'll be more than happy to assist you. Community health assessment support. So many tribal communities, the RPMS data that we have is not nearly as comprehensive as we need it to be. There's a lot that is not in there. So many communities want to do a community health assessment and just kind of get the pulse of not only the health conditions that are affecting the community, but other things as well. Do you smoke? Do you wear seatbelts? Do you eat 5 fruits and vegetables a day? Other things that affect health that communities may want to know about, so that they can develop some strategies to assist their citizens in obtaining good health. So we can assist with a community health assessment if a tribal nation would like to have one. We also, as I mentioned, data analysis. We mine RPMS all the time, but we can also, any data set that you would like us to analyze, we are more than happy to analyze it. In the past, we've gotten some state data sets at the requests of the tribes. I know years ago, the main tribes got together and wanted cancer data. So we got the cancer registry data from the state and mined that to look at the rates of cancer amongst the tribes. Survey and other data collection mechanisms of development, survey design. If any of you have ever designed a survey, developing a survey question is actually hard. You think it's easy, but it's really not. Getting a really, really good question that is not misinterpreted by people, not heard different ways by different people, and will give you the information that you're seeking. Immunization data assistance. So one of the things that we're able to do is Brian Hendricks has access to a few state immunization registries, and we're able to look at the tribal kids who have been immunized but have not been tracked in RPMS, but have been tracked through the state registry, and put that information in RPMS. So we've got immunization information for our kids. Data improvement training, RPMS is antiquated. We all know that. So we do quite a bit of how to improve your data within RPMS. Disease outbreak consultation. So pretty much almost everything else that we've done has been put on hold the past 18 months because we've been focusing on COVID. Disease outbreak consultation and making health recommendations. So we've written a lot of recommendations that we think tribal leaders should consider implementing in their own communities. And so we write those and we submit them to the tribal leaders so that they can make informed decisions. We also do provide some grant writing support. So if you're going after a grant and need to talk through a strategy or you need data to support your grant, let us know. And then we also do special requests. And that could be anything. Early on, I've helped with homework on more than one occasion regarding people have taken a public health class or needed some statistics class help. We've been able to provide that. So there's really not a whole lot that you can ask of us that we would not be willing to do. And if we can't do it, we will try to find somebody who can. So that is one thing that I think all of THPS prides itself on is our responsiveness to our tribal nations. A lot of times there's confusion about USET and IHS. So we do work fairly closely with the IHS team. A lot of the requests that we get is better handled on the IHS side. So we'll refer, and likewise, IHS will refer to us. So please don't hesitate to reach out to us should you need any assistance at all. Go ahead, Tav. And here's the COVID specific support, and I'm running a little bit short on time, so I'll kind of wrap this up. We've built a surveillance system. We've been providing weekly reports for, Imani, I think 63 weeks now. It's in the 60s. So since this pandemic, it was May of last year when we started doing it, I remember. Weekly reports to tribal leaders to just kind of monitor the local situation. We've been consulting with tribal leaders, businesses, departments, etc. We did casino consultation about how the casinos can open safely. We answer a lot of questions. The COVID landscape is changing almost daily. We get a lot of information in and sorting through the information about what is credible, what is not credible, what is a sensational headline that when you dig deeper down into the story, there's more to it. So we do a lot of that interpretation as well. As I said, we issue recommendations and provide public health communication materials. You may have seen that around. I know we've sent a lot of communication materials around for tribal communities to use. And Kev, you can go to the next one. This graphic on the right is one of the educational materials we had developed. We have that. It could be made into a flyer. It could be made into a poster. It could be a social media graphic. You see the USET logo at the bottom right. That can be removed and you can put your own tribal logo on there. So if there are any educational materials that you would like, please just let us know. I have our contact information. So if you have my email address, you can always email me. That's fine. But we have a USET, an EPI team address, and that way nothing falls through the cracks. It goes to all of us on the team. And it's usetepi@usetinc.org. We also have just recently submitted created a website link where we have one of those online forms that you can click on and fill it out, and it will come to us for request. Or, and this is the most, okay, Leslie, we can get that to you. Imani, if you could just make a note of that, we can get that to Leslie. We've got them all in a file that we sent out. And this is the most common method of communication, honestly. Folks just contact who they know, and then they're routed the appropriate, and that's perfectly fine too. We don't mind that. So with that said, I would like to introduce our other epidemiologists on our team. We have Imani Ransby, Emily Baer, and Dr. Harry Brown. Some of you may recognize Dr. Harry Brown. He worked for IHS until he retired, and then we hauled him out of retirement to come work for us. And Dr. Brown is a medical doctor as well. And we would like to give everybody the opportunity to ask us any questions that they may have, either on the services we provide, but we also, because there's a lot of new faces, if there are any COVID specific questions about the vaccination that you would like us to answer. Okay, I don't see any popping up. Tev has a list of questions that we're going to just answer as a panel. If this sparks anything for you, please just chime in and ask the question you may have. Go ahead, Tev.
Okay, so I have some questions here. One is what does a day in the life what does the day in the life look like at a TEC?
Does somebody want to take that? Or should I?
I can take a stab at it.
Okay, go ahead.
I want to say that this varies, but there's also a lot of overlap too, just because each tech has their own designated area or region, as we saw. And within that region consists a diverse landscape with multiple unique tribal nations. So I imagine that there is a lot of variability, but I also understand that there are apparent public health issues amongst AIN populations that are recognized by all techs. I cannot speak to a day in the life at another tech, but I do know what goes on at the USET tech, as I've had the opportunity to work at this tribal epidemiology center. And I would say the day often starts with a daily tech team huddle where we address pressing concerns for the workday and week. And then after adjourning for the morning, we attend meetings for our designated programs and work on projects that are assigned. Day to day varies for me, to be honest. I also expect there to be a lot of variability in my coworkers' work too, as we are working on different things throughout the week. So some days may be meeting heavy with a lot more information intake, where others may be a lot less, have a lot less Zoom interaction, where you're brainstorming your own ideas and working on assignments. But Christy, if you would like to add to that, if you have any more specifics, as I'm still kind of new to the
Yeah, Imani came on shortly before the pandemic, and Emily Bear and Dr. Brown too, shortly before. And Emily came on right in the middle of the pandemic, so they have not really experienced normal times just yet. We're hoping to get there, and I'll address this question that just came up. But yeah, we do a lot of consultation with tribal nations, some data analysis. We can do writing up reports. Writing up recommendations, discussing new information that comes out, just like, okay, so I was going to turn that one over to you. So the chat was, just saw a new study that states Moderna produces 2 times the antibodies than Pfizer. If that's true, why did Pfizer get full approval before Moderna? Is it just that the studies weren't completed and compiled? Yes. That's, Pfizer applied first, and it has to do with the length of the study period. Dr. Brown, do you just want to briefly mention, okay, not a study, just a letter and not peer reviewed. So this has been the bane of our existence, is the preprints. There is so much. Whoever thought that anybody would care about journal articles before they even got printed and before they even went to peer review? Nobody pays attention to journal articles in the first place, but now all of a sudden they're headline news. So that's been a big concern. The other concern is that the headlines they're designed to capture your attention. And so sometimes they capture your attention, but the information is not all that important, really. So, yeah.
I can add to that a little bit if you like. It wouldn't surprise me if Moderna, on average, does produce higher titers of neutralizing antibodies. Moderna actually uses about 3 times the dose of mRNA that the Pfizer-BioNTech vaccine uses. Although Moderna also has data showing that half their dose, 50 micrograms instead of 100 micrograms, will produce a very robust booster effect in people. And they're even talking about when Moderna boosters are given, they may only give half the dose that was given in the initial 2-dose series. So This is a very, very dynamic and fluid situation. You know, one of my jobs as part of the Tribal Epicenter is trying to keep up with all the vaccine information that's coming out. I have found that to be extremely challenging. There aren't enough hours in the day to read every study that's out there. But I would say stay tuned. Don't everybody run out and get a third dose of Moderna right now. Let's wait until, you know, the actual recommendations come out from the CDC. I mean, this is near and dear to my heart. I am almost 8 months out from my second dose of Pfizer. So, you know, I really would like to have this clearly in black and white so that, you know, I know what to do for my own self. But anyway, just be aware that every day something new comes out, and we just kind of have to wait and see where it's all going to fall out.
So, and then another question, what is the data that shows positive cases in those that have been vaccinated? Is there a current study of infection of the 3 vaccines? Yes, probably somewhere. Probably, I don't know of one in the US. And if they're looking at surveillance data, meaning the data, and this is where we get to academics, actual studies, and then looking at the surveillance data. The US's surveillance system is not great. I mean, I'm just going to level with you. It is not fantastic. And currently, we're only tracking hospitalizations and death of vaccinated individuals. So I'm not sure that we have robust information on that in the US. My guess is other countries do, and that's where I would look.
Yeah, that's a good point that somebody is making about don't forget about T cells. Also, don't forget about memory B cells. What I'm really seeing right now, and this is both from a clinical standpoint, because I work part-time as a hospitalist at the Cherokee Indian Hospital. But what seems to be playing out is that as levels of neutralizing antibodies fall, which is to be expected, that happens in disease states, it happens with vaccines, but the ability of the vaccine to stop the infection at the door, so to speak, you know, to keep you from getting infected, being contagious, getting symptomatic at all, that requires pretty high levels of neutralizing antibodies. We don't know what the level is needed for protection. And I think that would be variable in different individuals and different amounts of viral load that you get. So there are a lot of variables with that. But what does seem to be protective is the people getting severely ill and ending up in the ICU or in the morgue. So there have been very few deaths in vaccinated people. Your chances of dying if you're vaccinated, it's about 1 in 100,000. At least that's the current statistic. So they're very effective still because of those memory B cells, T cells, because the immune system is more than just antibodies. So, you know, the good news is if you've been vaccinated, I think you're pretty well protected against severe disease. What may wane over time, and the time line is still kind of unclear. You know, they're saying 8 months, 6 months, 5 months, you know, that's when the protection against infection seems to start to wane. And that's been a disappointment to me. You know, I had hoped that was going to last longer, but it apparently probably doesn't for most of us. I don't know if that answers the question, but that's kind of the summary of what I know today.
I'd like to address kind of a public health concern related to that, Dr. Brown, about transmission, that we keep having questions on about the vaccine does not reduce transmission. And my answer to that is yes and no. And I think people, and this is where we get into the difference about people thinking about their protection as an individual versus how we look at the community as a whole. So if you get COVID and you're vaccinated and you have a mild case, yes, you can absolutely still transmit it. So in that respect, it did not reduce transmission. However, if fewer people in the community are getting COVID overall, then transmission within the community is reduced. And so I think that that nuance is not communicated well. And there is evidence that even if you are vaccinated and have COVID, your time of transmission, the ability to transmit, is shorter. So, you know, I think that that message is not coming across in the education materials and the public health communications in the media, unfortunately.
Yeah, and if you're freshly vaccinated with with any of the three vaccines that we have in the US, you know, for a time after vaccination, and that time is going to vary in individuals, you actually do transmit much less. Even if you get an asymptomatic infection, it is so small, the viral load that you have is so small, you're not contagious. And that was shown to be, in the 80 to 90% range, but that was right after being vaccinated. So for the first few months after vaccination, yeah, those vaccines do block a lot of transmission. It's as those neutralizing antibodies wane that you're able to get infected enough to become contagious. But again, you're still protected from severe disease to a very high degree.
All right, it looks like we have a couple more minutes. I'll answer that question that just popped up. Are there any other questions, COVID or non-COVID? If you want to talk about something non-COVID, I think I speak for all of us when we say that would be greatly appreciated. We would welcome any non-COVID questions. Certainly we can welcome COVID questions too, but sometimes it's nice to not talk about COVID. So if you have anything else you'd like to ask, that would be great. So we could adjust the quarantine time for the vaccinated that has become COVID positive. If so, what would be the recommended time? Currently at my public health office, you will be quarantined for a couple of weeks. Well, a couple of things. So I believe the CDC recommendation is that if they're COVID positive, yes, you could potentially reduce the time. I don't know what that time would be. I don't know if the evidence is that they transmit for a shorter amount of time, but I'm not sure if we have a definite cutoff at this point in time. So for now, 2 weeks. I think if we get more information, absolutely we can adjust. Dr. Brown, Imani, Emily?
There are different strategies at this point for quarantine. You can do a 10-day quarantine with testing. There's even a 7-day quarantine with testing. But as far as vaccinated, so far, to my knowledge, the CDC has not come out with a recommendation for vaccinated versus unvaccinated as far as quarantine time. The 2-week quarantine is kind of the most conservative. But as I said, there's a testing strategy that you can use to decrease that quarantine time to 7 to 10 days. It's on the CDC website for those who are interested.
Anybody else? Any questions? All right. Thank you. And please don't hesitate to contact us for any reason. I know early in COVID, I fielded just brainstorming. What if we did this? What if we did that? And so we are more than willing to brainstorm with you guys and, let us know if there are any other health related data or statistics or guidance that you may need.
Thank you, Christy, and thank you to the EPI team as well for this presentation this morning. Again, as she said, if you have any questions, you can always reach out to them.